right, guys, it's just past 4 o'clock, so why don't we start going with some of our cases? Hopefully, more people will continue to trickle in and join us. I'm Jacob Kirsch with North American Society of Cardiovascular Imaging, and welcome everybody to our November edition of our Curious Cases webinar. So I put together a bunch of cases, and as always, this is an open forum. If any of you have cases available that you want to share with us, just let me know and I'll share the screen with you guys so you can present your cases. So let's see, I'm gonna now go ahead and show. See if it works. It should be working. There you go. Let's play this. Okay, so I have to share my screen, not the app when it's showing, so I can do this. You guys see the screen, full screen? Or the presentation mode?
No.
All right, perfect. All right, so again, we will be showing a few cases off-label use of gadolinium. As you know, the sticker doesn't say that it's to be used for cardiac imaging, even though we know we can use it safely. Case number 1. So we have a 60-year-old male, severe aortic stenosis, moderate mitral stenosis, secondary to radiation for Hodgkin disease back in the 70s. So a lot of radiation to the mediastinum. And as we know, that can create calcification of the valves, the vascular structures like the coronaries, etc. So he developed that aortic stenosis and underwent a TAVI procedure, which was very challenging from a technical point of view, according to the op report. Post-op, he developed worsening heart failure. So just want to show a few images.
Sorry, we don't see your screen yet.
You're not seeing my screen yet. All right, let me. We can fix that. Sure. How's that?
Yep,
Perfect. Fantastic. All right. All right. So we talked about this. I gave you the story: severe aortic stenosis post radiation therapy for Hodgkin's disease, had a TAVI, which was technically difficult, and then developed worsening heart failure post-operatively. So just gonna let the images scroll, and you guys can see if you can find anything that is that looks funny to you. And if anybody wants to make a comment, please feel free to do so. And I'll give you a still image with a finding in a second, if not.
VSD.
I'm sorry? Go ahead. All right.
I think she said VSD.
Maybe, yes. So the first TEE post-op day showed a small premembranous septal defect, which increased in size on the subsequent TTEs. Unfortunately, I don't have those images available, but they did measure a QPQS on the most recent echo, which was 2.4 to 3.1. So that's significant, right? Anything about 1.5 is physiologically significant. So I think you mentioned that there's a small septal defect there at the site of the membranous septum, just underneath the valve. You can see the communication there. And this is another multiplanar reconstruction, again, right here below the valve. I don't know if you can see my cursor. I'm trying to show it. Let's see. I have drawing tools here, just in case. So, all right, they're not working. Okay. Anyway, so here is the VSD. So again, it's a rare complication, and it's difficult to know why they do happen in a few patients, but it's likely multifactorial. a few of the cases in published studies in the past about this perimembranous VSD post-TAVI report that there was a need for post-dilatation of the aortic valve when there was residual paravalvular regurg. And again, that's on the core valve implantation. So those are the self-expandable TAVIs. The one that we see on this image is not a core valve device. It's not self-expandable. It's balloon expandable. Again, oversizing may have to do with the aortic rupture and perimembranous VSD on these cases. And again, there's other potential causes for acquired VSDs of the membranous VSD, or the membranous septum, I should say, puncture from calcium front, metal struts of the prosthesis, or a wire, etc. The asymmetric calcifications has also been used as an explanation because it leads to distorted expansion of the stent where the valve is located. There's a good study of retrospective 72 patients that underwent using a sapien prosthesis, like the image that I showed, and that contained the aortic rupture right at the site of the annulus. It was more common in patients that had a valve oversizing by CT, patients with a relative oversizing of more than 20%. I put the reference there at the bottom if you guys are interested. And again, this is from data that Dr. Jonathan Lipsick presented a few years ago already at RSNA, and it also was presented or it was published, I'm sorry, at the Journal of the Cardiac Computed Tomography. And you can see there that the highest predictor of rupture or subannular rupture is the subannular calcium right below the non-coronary cusp. So that asymmetric coarse dense calcification that we see that happens and kind of tracks apically or towards the subannular region or membranous septum, that is an indicator that there's a risk of subannular rupture. And you can see there the region under the curve in those graphs. When you talk about the aortic valve and calcium volume, that's the one that reaches most towards the top and left of the graph. So it's the highest predictive value. This is another case. This is without contrast here, but we see a little bit of high attenuation pericardium there. And then you can see here when you do with contrast, you can see there's a small annular rupture. It's a contained little rupture. You can see some contrast there right below and posterior to where the valve was implanted. There's the TAVI that was recently placed, and there's a bit of hemopericardium. Also, the fluid in the pleural effusion was a little bit higher in attenuation, suggestive of hemothorax. And again, this is a complication of the placement of the TAVI it is a different patient, of course. And that is that, just a case and a comparing image of focal damage to the subannular structures after TAVI placement. Any questions or comments to those cases? All right, very good. Here we have a case. Let's see, this case number 2 with a patient status post heart transplantation, orthotopic heart transplant. The needle count was off intraoperatively, so of course they did a few x-rays to rule out foreign body. So any comments? Anything that catches your eyes, guys? All right, we'll come back to this image. So there was no needle was identified. The needle count was off, so there was nobody saw a radiopaque structure that looked like a needle, and there's all these tubes and lines. You can see there the TE probe as well in the esophagus, just posterior to the heart. And then the patient went to the unit, and this is a follow-up image. Anything interesting here? All right, so we see here, we see the endotracheal tube here. We see a mediastinal drain here coming from below, another mediastinal JP type of drain here, kind of draping over the heart, a chest tube, some epicardial pacer wires here on both sides. And then we have this linear radiodense structure that doesn't seem to communicate with anything. And this MIP of the CT that was performed afterwards that again redemonstrates that structure there in the pulmonary artery. Potentially here we see it again on this MIP in the oblique axial plane. Again, this is this is the one in the OR. We're going back to that first picture, and under further review, we see this structure here overlying the heart, the lower part of the heart, so potentially within the right ventricle, that doesn't communicate with any of the stents or drains. So the theory is that there was a fragment of a line that was in the right ventricle that then embolized into the pulmonary artery in the post-op period. So patient was taken to the interventional suite, and you can see there this piece of a catheter there overlying the right lower lung, and a wire with a snare reaching out into the SVC, right ventricle outflow tract, right pulmonary artery, and then trying to snare it and taking it out through the right IJ, and then confirm that that was the end of a potentially catheter, a Schwann-Ganz catheter was the thought. So this was a fragment. Interestingly, you see there's a very nice clean cut here proximally. So this was a foreign body that came with the transplanted heart. So during harvesting, and they did the harvesting on the heart, that they cut the SVC and the IVC, and of course the left atrium as well. But when they cut the SVC, the patient had a line in place, and they didn't realize that the end of that line had remained within the patient and in the right ventricle. So when the new heart was put in place, that catheter came with that heart. So it's a foreign body within a foreign body, I guess, if you think of the transplanted heart as a foreign body. So just a very kind of interesting story to a relatively straightforward image. Case number 3, I think I have like 4 cases in this presentation, then we can see if anybody else has more cases. If not, I can come up with a couple more. But let's look at this one. So case number 3. This is a 46-year-old female, post-op period. We don't get a lot more information than this. And again, this is a cardiac post-op. This is as the patient gets to the surgical ICU in the immediate post-op period. And again, we look at all the lines. We have the endotracheal tube, right IJ, central venous catheter. Seems like there was a port here on the right, mediastinal drains, sternotomy wires. Here's a valve, aortic valve. But then we have this structure here overlying the left silhouette here. There's a curvilinear radiodensity, looks like a needle, like a surgical needle. And then we have the lateral view, and we see here in the posterior heart, or just behind the left atrium, this linear radiopacity, which corresponds with that foreign body that we saw on the initial AP view. So retained needle. So the patient was re-explored, but they could never find the needle. They could not find this radiopaque structure. So pre-op, you can see a couple of things that changed. Number one, there's no needle here. The sternotomy wires look different. So it was a reduced sternotomy. And the other thing that looks different is the valve prosthesis. You can see it's a different type of valve that was placed in the intervalve. So it was a revision of a valve prosthesis that happened. And this is just 2 views, so 2 reconstructions of this post-op period, again showing that radiopacity. Now here posterior to the heart, it kind of moved a little bit more cephalad from the lateral chest x-ray. We see it here and we see it here. So here on the axial view post contrast, we see that it's right here in the pericardial space, potentially just posterior to the left atrium. In the oblique sinus. So again, it's thought to be in the pericardium in the subsequent CT, right behind the left atrium, like we said. So they went back and reviewed what the valve looked like, the one that was removed on the revision. They noticed that one of the wires of the structure, the skeleton of the valve, was broken off, and there was a fragment right here marked with these white arrows. That part of the valve had broken off during the procedure. So what we were looking at on the chest x-rays was not a lost needle, but it was just a piece of the valve. So again, just another case of an interesting story for a retained foreign body postoperatively. Case number 4. So chest x-ray. Anybody wants to comment on it? Looks funny. I'll give you more story after somebody comments. Any brave souls out there?
Could be a pericardial agenesia or something like that.
Okay. Would you like to describe what the cardiac silhouette looks like a little bit?
The left cardiac silhouette is not round as normal, is mostly displayed leftward. So if there is a trauma, it could be like sequestration, but if it's no trauma or only normal, it could be like pericardial agenesia or something. Yeah.
Perfect. Yeah, that's great. So yeah. Go ahead.
We don't see well the diaphragm on the left compared to the right, so but maybe it's the superposition. So CT scan can be helpful.
CT scan is always helpful. All right, so that was very good. So yes, there's some deviation of the silhouette. We don't really see the right cardiac contour, and when it really overlies over the spine, that's when you start thinking about deviation, and can there be some issue with the pericardium, right? That has been described with the absence of the pericardium, either congenital or iatrogenic. Also, this upward elevation of the apex, I think it has been described as the Snoopy sign. It looks like Snoopy, the cartoon dog, Charlie Brown's pet, and it kind of looks like that a little bit. So the story in this patient is patient had surgery for pericardial penetration from a knife stab to the chest. So let's look at the pre and the post chest x-rays here. And there you go. So looks pretty normal. And again, like a couple of things that I mentioned, you see the right cardiac contour is to the right of the spine. Here it actually is behind the spine. So I think you mentioned the question of trauma. So that was pretty on point, fantastic, really good observation. And that's what happened with this patient. And the patient did go to CT because, like we said, a CT can be very helpful in most cases. And you can see here the heart is deviated. We don't really see a good pericardium towards the apex here. We kind of lose it, but as we scroll, not only do we lose it, we see that the apex of the heart is herniating through that defect a little bit, has that waist around it, which can be troublesome and may lead to further problems. So that needs to be decompressed to some degree. And again, this is just a reconstruction showing that upward positioning of the left ventricle. So again, this is a pericardial defect. This from the literature, some of the information that I was able to gather. Again, it's interesting that the tendency of the heart to herniate through a defect is not necessarily related to the size. Even a small defect can have a herniation through it, which it was it's a bit counterintuitive. I wasn't expecting that necessarily, even though I had seen a bit of a herniation through smaller defects in the past. The adjacent pleural pressure is reduced, and that draws the heart out through the pericardial defect. So that may explain some of that. It's not just the pressure within the pericardium, but that negative pressure in the pleural space that predisposes some of that herniation type process. Again, if we put that pleural tube with the through thoracostomy, that negative pressure also may promote herniation of the heart through a defect. And again, that motion of the left ventricle may predispose to herniation as well. So that heart that's just kind of jumping in there. All right, and those were the cases that I had kind of put together as a presentation form. There were a couple of comments here on the chat box. Let me just look at them. Yeah, so somebody talked about the linear structure. Susan, you talked about that. Yep, on point. So those comments, and somebody picked up the VSD. Also very well, good pickup. Does anybody in the group have any cases they wanna share? I see a few familiar faces that sometimes have cases. Mike, you have a case?
I can share a case, but I just got back to my computer, so give me a minute. I got to log back into my
No problem.
software.
I have some other cases that I can show in the meantime. Anybody else would like to share a case?
Sorry, I don't have any right now.
All right, no worries, no worries. There's, this is a friendly environment, so anybody is more than welcome. If not, I'll try to show a couple cases. Let's see. So there's a case that I put together for. I didn't put together. There's my pointer. Want to make sure which one is it. Let's see this one. I'm gonna show both cases anyway. All right, here we go. Let me look at the images. Okay. So this is just a very straightforward case that I saw recently. Just a very, very nice example. You see this jet of contrast here from the left atrium into the right atrium, right, pretty central. Consistent with the patent foramen ovale, and you have the jet of contrast. And I was looking for images. I have a really nice case of PFO that we saw back in about 2001 or 2002 when we first started doing a good number of cardiac cases, like at the Cleveland Clinic in campus. I was a resident back then, and we had very little experience with some of these cases. And all you could see was you couldn't see the jet of contrast, but you could see the gap at the PFO. And I remember that the staff clinician back then questioned if there was a dissection of the left atrial wall after instrumentation, because again, we had really not seen this many CT cases, and we're all trying to put things together. So it's nice to, that now we're very confident when we make this type of diagnosis now on CT. So again, just a very, very nice case. And actually, we can do a quick coronal recon here, and right there you see the jet of contrast coming through quite nicely. And the other case is the one that I kind of posted yesterday on Twitter, just to try to get people interested in seeing the answer today during the webinar. This is a patient. Let's go down here to the abdomen. It's not very obvious that the patient has cirrhosis, although there is some splenomegaly, and you can see there's a lot of varices going through the GE junction here. All of this, you see all these varices, so a lot of paraesophageal varices, very prominent. And then this is the finding that I was showing here on Twitter. So there's a luminal filling defect here. However, that's not the pulmonary artery, right? That's the left inferior pulmonary vein. So anybody wants to comment on that, what that could be? It's Osiris is acting out, acting up. I should let's do a quick recon. All right. So here we see the filling defect in the left inferior pulmonary vein, and you see it's coming from the paraesophageal varice. So that's just unopacified blood. So there's a portopulmonary fistula here. So those paraesophageal varices tend to connect with the pulmonary venous system, or they can also connect directly into the left atrium. So that's what we're seeing there. That what looks like a filling defect is really unopacified blood from the portal system refluxing into the pulmonary artery. Let's go back to the original. Here you see it there very well. So you can follow here the paraesophageal varices as we go up and how it drains into the pulmonary vein. And just let's see, where's there's a paper that we published a few years ago. So we looked at 150 subjects.
Does the patient have any procedure, any electrophysiological procedure or anything?
This happens in patients with cirrhosis, patients with varices. So what we looked at, we did a study looking at the prevalence of portopulmonary shunts. There's not a lot of this in the literature, and especially on CT. Again, there's something on portography and echo that are really, really old studies. We published this back in 2012. We had 150 patients with cirrhosis and who had a triple phase CT. And actually, out of 150, we found 18 of those didn't have that, but 26 had a portopulmonary shunt. So almost 20% of these patients may have one. So if you pay attention and you look for them, it's quite likely that you will find one of these shunts draining again into either the left atrium or the pulmonary veins. And again, presence, of course, was associated with varices, endoscopy, ascites, thrombocytopenia, and splenomegaly. So those were the independent variables or factors that we found had an association with the presence or absence of portopulmonary shunts. All right, so those were my cases. And any other questions about these ones? All right, Mike, you ready?
Yeah, I got mine to pull up here. Actually, it's just a case from like 20 minutes ago, so it's hot off the press.
Those are the best ones.
Yeah, right. Exactly. So let me, how do I share? Okay, sure. Can you see my screen?
Yes.
So, so this is a patient who's in the hospital right now. It's a 31-year-old woman who had a some kind of congenital mitral valve issue that was repaired surgically with a bioprosthetic mitral valve replacement in 2015, so about 5 years ago. And she's been having intermittent symptoms and finally, but has been sort of lost to follow-up. She had a baby about a year ago and showed back up to her primary cardiologist office with complaining of dyspnea and heart failure symptoms. And they did an echo and her mitral gradient was 27. So severe mitral regurgitation, severe mitral stenosis is a gradient more than 10, and hers was 27, so quite high. So they need to fix this, and the surgeon, for reasons that I'm not entirely sure about, is not inclined to go and redo a sternotomy on her and redo the MVR. And so was asking if we could, just to look at the anatomy for potential TMVR. So this would be a valve-in-valve transcatheter mitral valve replacement. Again, that is not typical for many reasons. She's not prohibitive risk, but nonetheless, we're entertaining the option. If you look at outcomes for transcatheter mitral valve replacements, valve-in-valve really has the best safety profile, especially compared to valve-in-ring or valve-in-MAC especially. So these are pretty straightforward procedures on a relative basis. If you know what you're doing, and the anatomy is pretty straightforward because you can define the mitral annulus quite easily. So can you see my screen here? So this woman had a 29 millimeter Edwards paramount placed in a mitral position. And then I traced the ring size, which is just short of 27 millimeters. And if you look on the Viv app, it's 27. The true ID is 27. So that's about right. And so the next thing that we do here is, as most people will do, is you'll put in a virtual valve. So for a 27, you could you should put in for a 27 millimeter true ID is a 29 millimeter valve, you'd put in a 29 millimeter Sapien S3 in the mitral position, so this is a virtual 29 millimeter valve in the mitral position, a 29 millimeter Sapien, excuse me, in the mitral position. So, and that's what you can see here. And then you have to do an offset, and that's just has to do with how atrial the valve needs to be so that the skirt portion can sit properly along the ring. And so that's typically a 20% offset. You could go 10%, maybe even 30%, but typically it's 20%. So that's what's reflected here. So this, the height of the Sapien 3 is for a 29 millimeter Sapien 3 is 22.5 millimeters. So we 20% offset would be 5 millimeters back. So this is again is the mitral ring here for the prosthesis. So it's set back about 20%. And then as everyone knows, we look for the, we try and calculate the neo-LVOT, which is what was done here. It doesn't matter too much for your neo-LVOT, even if it's small as it is in this case. I guess it's not showing me unfortunately the measurements, but this ended up being right around 1.3 centimeters squared. And the question is, what's the threshold for LVOT obstruction? How do you find LVOT obstruction? All good questions, but a ballpark number to avoid a significant increase in gradient, which I think is what most people are now using as a surrogate for LVOT obstruction, is going to be, you want a threshold of 1.8 centimeters squared, and that's based off some work from the Cedars group. They've published the most on this, or at least the largest case series. So this is 1.3, so you'd say, well, that doesn't meet the threshold. She's going to have a LVOT obstruction. However, because she already has a mitral valve in place, you don't really have to worry about LVOT obstruction here, because you don't have the normal mitral valve is a bicuspid valve, but the surgical valve is a tricuspid valve. So you've effectively split the leaflet. So you'll always get flow out the LVOT and systole, even if you're encroaching here on the flow in the patent part, or the part where the virtual valve doesn't extend into the LVOT. You still have additional flow that can get through this part here, because there's a split because of the surgical valve is tricuspid. But there's one important caveat to that, and that is the assumption that the virtual valve, the valve that you're implanting, does not go beyond the posts. And so what's interesting in this case is that with a 20% offset, you can see that actually the virtual valve is going to extend significantly beyond the posts. In fact, it's about 3 millimeters or so. And so then you do really have a risk of developing LVOT obstruction. So what I did instead is I modeled a 26 millimeter valve, which is, so the Sapien S3s come in 23, 26, and 29. And so when you model the 26, you get an LVOT, neo-LVOT of 1.8, but more importantly, you're no longer going beyond the posts, at least not to a significant extent, and that's what you can see here. Oops, sorry. So it's only about 1 millimeter or so beyond the post, which I think is within the margin of error, and then your neo-LVOT is acceptable. So the problem then becomes, well, now you have a 26 millimeter valve, and is it going to slip out? And so we can get beyond that also by just modeling a 26 millimeter valve with overexpansion. So these are balloon expandable valves, so you can add extra cc's and overexpand the valve. And so if you add, and there's papers that have validated this, including one that we've written, that show that if you add an extra several cc's, 3 cc's to a 26, it expands out to a 27.5 millimeter diameter, which is what I'm trying to put in here. But anyway, the good news is then that fits pretty nicely. So what I told them is that what I think you should do, even though the valve app says, the app says to do a 29, I think you should do a 26 with 3 to 4 cc's of overexpansion, which will allow you to fit the valve nicely if that's what they decide to do, without the risk of embolization or PVL, but avoid the risk of LVOT obstruction. So I know this is super granular, but I thought it was kind of interesting, just because you can't just sort of put the valve in and just hit play and go, but you got to think about all these other sort of subtle facets to just reduce the likelihood of a bad outcome. So that was this case that we just had like half an hour ago.
Thanks. Thanks for sharing. Any questions? I mean, that's a lot of really good information.
Yeah, so I would say for those who are doing, transcatheter valves, obviously a 31-year-old patient is not going to be your typical patient, but if you're, it's the common thought is, oh, it's just a valve and valve. These are pretty straightforward, and they are for the most part. But I think the critical thing to recognize if you're doing these, and if you're modeling putting in the virtual valve, is just to know that it shouldn't extend beyond the post. If it does, then you need to start worrying about your LVOT, your neo-LVOT area. If it doesn't extend beyond the post, then you're golden. So.
Perfect. That was great. And there's a bunch of comments on the chat room, Mike, about the TMVR tutorial, how good it was. So we should talk about putting a series for maybe for next month or the month after.
Yeah, absolutely. Not a lot of cases. So
awesome. Perfect. Very good. All right, guys. Anybody else wants to share a case? All right. No pressure. I think, I mean, we had a good number of cases. Let's do me a favor. So I think that's the cases that we have for today. But before you log off, if you don't mind, just put in the chat window, if you haven't, where you're from, where are you joining us from, just for us to get an idea of where people are logging in from, and how did you find out about this? Either was it a NASCI email blast, Twitter, a friend told you, did Dr. Litmanovich forced you into joining, like I think some of you are? I'm kidding. But that'd be great information. So thank you all for joining. I'm going to leave the chat open for a few more minutes so people can actually chime in. Okay. Thank you, guys. Thanks, Mike, for sharing.
yeah, of course.